around the ankle joint. It can affect both amateur and professional athletes, and we can see soft tissue impingements and osseous impingements, which can cause chronic ankle pain in younger populations and athletes, and even in older populations. It usually arises from initial ankle injuries, which in subacute or chronic cases may lead to abnormal osseous or soft tissue thickness with altered biomechanics. Right. So today, what I'm going to do is teach you or maybe discuss, learn pertinent radiological anatomy of the angle to understand imaging features of common types of impingement and develop an algorithm and for diagnosis and further management. So etiology is always interesting, and we should know how the pathology arises or what are the causative features. The etiology of impingement can be due to post-traumatic synovitis. It can be due to fractures or malunions. It can be due to scarring, recurrent sprains, and many osseous causes. We'll deal with each pathology when we are dealing about the specific impingement. I tend to follow a segmental approach in all my joint imaging, and that helps me to, not to oversee or forget any part of the joint because ankle impingement is given the breadth of causative mechanisms and preferred treatments for ankle impingements, they can be subsegmented into various anatomical regions. This include anterior impingement, which can be divided into anterior lateral, anterior medial, and anterior proper. Then we have posterior and posterior medial impingement. Then we have talk about extra-articular talocalcaneal and subfibular impingements, and maybe talk about some miscellaneous impingements if we have time. So the diagnosis of ankle impingement is primarily clinical and not radiological. So now you may ask, what is the rationale of this talk if the impingement is diagnosed clinically? So the goal of imaging is to provide morphological information, like what is the cause of pain, are there any corroborative findings? Are there any corroborative anatomical findings which is leading to impingement? Are there any associated other pathologies which may change the treatment outcome? And also, using imaging, we can do therapeutic decision making after discussion with our clinicians and also aid in guided interventions. So, we have multiple imaging modalities, but the diagnosis, as always, is primarily clinical as we get patients which are referred from the orthopedicians. We can see sometimes radiographs which can help us to provide osseous informations. CT scans are better when we are talking about extensive bony abnormalities or to identify occult bony abnormalities. Ultrasound is a beautiful tool when done by an expert. We can identify the cause of impingement, we can stage the disease, and we can intervene accordingly when we are using an ultrasound. However, MRI is the workhorse for most of the impingements as it aids in identification of the pathology and also in identification of other corroborative findings. So let us come to the most common type of impingement, that is the anterior lateral impingement. It occurs as a complication of flexion inversion sprain injury. Patients usually present with pain and swelling along the anterior lateral aspect of the ankle joint, and which usually increases when the patient is squatting, doing ankle inversion or dorsiflexion. So the pathology or etiology that is suggested is basically it has a complication of a long-term flexion inversion sprain injury, which leads to either debris formation or synovitis in the anterior lateral recess. It can be associated with a tear of anterior talofibular ligament. When there is recurrent synovitis, it may lead to formation of fibrotic tissue. Sometimes there might be robust hemarthrosis and synovitis, which can coalesce together to form a meniscoid lesion like this or a fibrinized mass along the anterior lateral gutter or recess. Before talking about anterior lateral impingement, let me talk about the anterior lateral recess because that will form a concept for you. So, what is the anterior lateral recess? It is basically a pyramidal shape which is formed medially by the tibia, laterally by the fibula, superiorly by the anterior inferior tibiofibular syndesmosis, inferiorly by the calcaneofibular ligament, and anteriorly by the ATFL and the joint capsule. Once we are thorough with the graphics, let me try to reciprocate this actual space on an MRI. So, as I told you, it is a pyramidal shape, and this is the actual space that you want to look at carefully when we are talking about anterior lateral impingement, right? Sometimes there is synovitis, sometimes there is a hemarthrosis, and there might be some abnormal soft tissue here which can lead to impingement. Let me take you through a scroll or stack of images and again help you in identifying the anterior lateral recess. So what we are seeing is the tibia and fibula, and as we go inferiorly, we can identify the inferior tibiofibular syndesmosis here, right? And further, as we go down caudally, we can see that pyramidal apex of the pyramidal shape that is forming, and this is basically your anterior lateral recess. What I'm talking about anteriorly, which is bound by the anterior talofibular ligament and the capsule. So be careful when you are evaluating this area when we are talking about anterior lateral impingement. So very commonly asked question is, do all lateral ankle sprains land up with impingement? The answer is no. It is an uncommon sequelae which follows only 2 to 4% of the sprain injuries. So what happens when we have a chronic sprain injury? We have ligamentous and capsular tearing, which leads to secondary microinstability and hemorrhage, which I have already reiterated. It causes synovial hyperplasia and scarring in the anterior lateral gutter. So, what are the imaging findings that we can see? On a radiograph, we can see any osseous bodies, loose fragments, osteophytes which are projecting over the anterior lateral gutter. We can see thickening of the ATFL, AITFL, or CFL, which are chronically remodeled. We can identify focal synovitis or meniscoid lesions. On MRI, we can assess bone marrow edema, contusions, and irregularity. Apart from this, we can also see some other structures, for example, Bassett's ligament. Sometimes we can see small ganglia and anterolateral tibial plafond. Sometimes they might be avulsed osseous fragments or syndesmotic ligament complex injury, which can present with anterior lateral impingement. Ultrasound aids in diagnosis as well as guided injections. Let us go through a few cases of anterior lateral impingement. So what we have seen here is a thickened ATFL, and I have a comparative image for you. So what we are seeing, it is a chronically sprained anterior talofibular ligament here. And for your comparison, this is how a normal ATFL will look like. Because of the thickened ATFL, there is obliteration of the anterior lateral recess, and there is associated synovitis, or there is associated obliteration of the recess, which is causing pain to the patient. A similar case, what we are seeing here is thickening of the ATFL as demarcated by the arrows. What we can see is there is associated edema, and there is obliteration of the fat of the anterior lateral recess or gutter, and it is replaced by hypointense soft tissue here. So there is thickening of the ATFL, there is associated synovitis and thickening. Another case wherein we can see thickening of the ATFL, we can see synovitis, and if we look carefully, we should try to identify any small bony avulsions which may occur with sprains. For example, in this case, we can see a small bony avulse fragment here, which is beautifully seen on a corresponding CT scan. So this is a case. He was a 41-year-old avid marathon runner who had an ankle sprain, and which he neglected and basically presented with chronic anterior lateral pain. What we are seeing here is diffuse thickening of the ATFL. There is obliteration of the anterior lateral recess with presence of hypointense soft tissue, and also malunited or non-united fracture with adjacent edema, right? So sometimes neglected ankle sprains will present to you with such meniscoid soft tissue masses along the anterior lateral recess, which can cause impingement. Sometimes there can be thickening of the Bassett's ligament. So what is Bassett's ligament? It is an accessory anterior inferior tibiofibular ligament which runs parallel to the AITFL. and it attaches from the tibia to the fibula. So this is a graphical, this is a true dissection image which I have taken from this article. And if there is thickening, this is usually present in 70 to 90% of the ankles normally. When there is thickening or injury of this ligament or remodeling, it can obliterate the anterior lateral recess and again cause symptoms of anterior lateral impingement. Similarly, for example, in this case, he was a 41-year-old male who presented with chronic history of anterior lateral sprain, and we can see a huge bony spur here. There is obliteration of the recess and thickening and capsule of the capsule. So this is again a bony capsule formation. Sorry, this is again a bony irregularity which is causing anterior lateral impingement, and we can see corresponding edematous change. And this is the corresponding CT scan. So next comes the role in literature is of about MR arthrogram. Is there any role of MR arthrogram? So MR arthrography, according to to the literature, is important when you cannot see any fluid within the joint and when you are not able to make out the anterior lateral recess. So according to literature, after doing an injecting an ankle with contrast, if there is absence of a recess of fluid between the anterior lateral recess or the anterior lateral soft tissue and anterior surface of fibula, it is indicative of anterior lateral impingement. It secondarily indicates that there are adhesions between the capsule and there is scar tissue which is preventing fluid from entering the normal recess between the fibula and the joint capsule. Although I have less experience of doing arthrograms in such cases, but this is the reference that I have used for arthrograms. Coming to another very common type of impingement, that is your anterior impingement. It was first described in soccer players. It is often termed as athlete's ankle or footballer's ankle. And patients usually present with plantar flexion, painful plantar flexion at the tibiotalar joint. Now, etiology that has been stipulated for this, it is repetitive capsular inflammation and synovial inflammatory response, which in itself will can cause pain along the anterior aspect. Now, due to the repetitive motion, as we can see in the graphics, there can be formation of bony spur and scarring, and there can be capsulitis here. So what happens is due to repetitive motion, as we see as a footballer tackle, as a footballers kick repetitively, there might be secondary scarring and bony spur formation. So patients usually present with chronic ankle pain on dorsiflexion of the foot, and there is restricted range of ankle motion. X-rays may be helpful in identifying the bony spurs at the tibiotalar joint, and MRI can be used to identify synovitis and fibrosis at the anterior recess. Now, there is a lot of debate that whether we should call these bony spurs that we are seeing here as osteophytes or syndesmophytes. So, when I went through literature and found this interesting paper which talks about the correct nomenclature for this, so whenever there is formation of the bony outgrowth extra-articularly, that is secondary due to capsular and ligamentous traction, and it is present along the lateral aspect of the anterior ankle. It is usually an enthesophyte, and when there is such bony sphere present medially and is intra-articular, that has to be termed as osteophyte. So let me show you some examples. So this was a 35-year-old female who had pain in her ankle joint along the anterior aspect. And what we can see is subtle dorsal anterior tibial and dorsal talar neck osteophytes. There is thickening of the capsule and fibrosis. A point that I would like to emphasize here is that look at the attachment of the capsule. It is not directly at the site of enthesophyte or the osteophyte formation, but it extends slightly anteriorly and superiorly, and it is not at the just at the juxta-articular margin, right? So this is exactly the attachment site of the ankle joint capsule. So another case, sometimes we can see profound bony spurs which are forming at the superior aspect of neck of talus and anterior tibia. We can see joint diffusion and thickening of the capsule, and patients usually present with ankle pain. Another such example, apart from the bony spurs and thickening of the capsule and effusion, we are supposed to look at any associated chondral injuries, presence of any osteochondral defects, right? Because that will aid in guiding the management of the patient. A rare type of impingement, which is an anterior medial impingement, it happens again due to the patients usually present with pain during dorsiflexion and inversion. The mechanism is stipulated to be a rare complication of supination injury. It was earlier thought to be due to pronation. However, the recent literature says that it is due to a supination injury. It is associated with, can be associated with recurrent microtraumas or acute injuries. We can see bony spurs along the talar neck and the anterior medial tibial performance. There might be avulsion fractures and dystrophic ossification. Before talking about anterior medial impingement, let me take you through the anatomy of the anterior medial gutter, because that will again help you in identifying the diagnosis. So anterior medial gutter or recess is basically formed superficially by the anterior medial joint capsule, laterally by the talar dome hair, medially by the medial malleolus, and inferiorly by the anterior tibiotalar fascicle of the deltoid ligament. So, what happens in a chronic supination or a rare form of injury is that there is thickening of the anterior tibial fascicle of the deltoid ligament, which gets remodeled, causes obliteration of the anterior medial gutter or recess, and patients usually present with anterior medial ankle pain. Let me try to show you the anterior medial gutter or recess here. So this is the anterior band of the deltoid ligament, and this is the anterior medial joint capsule, and this is exactly the anterior medial gutter or recess, the space that I'm talking about. Patients are usually present with, pain along the anterior medial ankle, and due to acute injury, there might be acute injury, there may be chronic repetitive injury, there might be thickening or damage of the anterior tibiotalar ligament, there might be associated synovitis, bony osteophyte formation. The X-rays may show osteophytes, right? MRI may show, abnormality of the deltoid ligament. There might be associated synovitis here, capsular thickening, or osteochondral lesions. So this again will cause impairment on the range of motion. And for athletes, we who need proper range of motion, this can be a limiting factor in their sports. So this is a case from the literature that I reviewed in which they showed a 20-year-old female who had ankle sprain, which increased progressively. The X-rays can show X-rays are showing enlarging osteophytes at the medial aspect. So there is a role of radiography when it comes to anterior medial impingement, and exaggerated oblique view projections can be used to visualize medial talus, tibial plafond, and medial malleolar osteophytes. So MRI in such cases may show osteophytes, there is synovitis in the anterior medial recess, and there is adjacent bone marrow edema. So what we are seeing is a remodeled anterior tibiotalar portion of the deltoid ligament. We are seeing obliteration of the recess with presence of hyperintense soft tissue along the recess or gutter, and which is causing anterior medial impingement. A very common type of impingement, that is posterior impingement. It can occur due to repetitive microtrauma, or it is associated with plantar hyperflexion injuries in patients. We can see such injuries in footballers, in kabaddi players, and classically it has been described in ballerinas due to their pointy technique. So what happens is because of the acute plantar hyperflexion injury, there might be impingement of the soft tissue between the bony of the structure, and patients will present with posterior ankle pain and swelling, which can be worsened by plantar or flexion or dorsiflexion of the crater. Before talking about posterior impingement, a word about the posterior talus anatomy. It is important in development of posterior impingement. So some anomalies which can cause posterior impingement include, so what classically it has been described that a secondary ossification center forms between 8 to 13 years, and it fuses with the posterior process of the talus by 13 years, or it fuses within 1 year. If there is failure of fusion of this is ostrigonum. If there is prominence of the posterior lateral process, it is called a cedar process. So ostrigonum cedar process, what such osseous structures which are present there can cause impingement and can cause posterior impingement. Right? So what we can see on a radiograph, we may see presence of cedar process or os trigonum. MRI may show bone marrow edema, soft tissue edema, capsular thickening, and as the flexor hallucis tendon is in close proximity to this, we can see tenosynovitis or praying. Because of the secondarily hypertrophied soft tissues between the posterior talus and calcaneum, there might be pain to the patient, right? And commonly what we see is flexor hallucis tenosynovitis, which is associated with this. Also, there is injury to the posterior ankle ligaments when we are talking about posterior impingement. So, a word about the posterior ankle ligament in anatomy. So, there are three most important ligaments that are the posterior inferior tibiofibular ligament, the posterior intermalleolar ligament, and the posterior talofibular ligament. So all the three can be injured depending upon the type of impingement on various grades, and you need to identify each of them and their pathology. What happens when there is posterior impingement? These ligaments may be interposed between the bony structure and may tear. There might be secondary degeneration in this, which you need to mention in your reports. Right? I hope I am clear till now. Let us talk about role of radiographs in posterior impingement. Radiographs play a vital role. We can identify abnormal bony structures which can cause posterior impingement. For example, in this case, we can see an elongated posterior cedar process. MRI beautifully depicts tenosynovitis, right? So what we are seeing is the flexor hallucis longus here with there is tenosynovitis, and there is a prominent stira process, and because of the persistent impingement here, there might be resultant tenosynovitis and can cause posterior impingement. Sometimes we have os trigonum. What we can see is edema along the synchondrosis that is forming here. We can see effusion, right? And so this was a case of os trigonum with edema and posterior impingement. This was another case in which there was an elongated stira process, which is like a bony spur, right? And which is causing impingement, and there is effusion. One thing what MRI helps is MRI may help you in differentiating other causes of posterior impingement. For example, the patient will present with posterior ankle pain. We can rule out Achilles tendinitis. We can rule out acute any posterior talar process fractures. We can rule out isolated flexor hallucis tenosynovitis. We sometimes there might be Haglund's, in which the patient is having posterior pain. We can identify retrocalcaneal bursitis or osteochondral lesions, which can mimic posterior ankle pain. So here comes the role of MRI. Apart from these, you get a holistic picture of the other structures that are around, and that can help you in identifying all the causes. So let me show you an interesting case. So this was a 33-year-old male who presented with posterior ankle pain. So I'll give you 30 seconds to go through the radiograph and try to identify if you can any abnormality, and then we talk about the findings in further slides and sections. So once you are reviewing this radiograph, you'll start from the maybe the cranial part or the caudal part, depending upon your approach, and you'll start tracing the bony articular margins. And maybe you can appreciate something here. When you trace the talar dome, maybe you can appreciate this bony projection here, right? So apart from this, we are not able to see other structures. But if the patient comes to you with anterior ankle pain and such bony projections, you might be thinking of anterior ankle impingement, right? So let me show you a section of MRI for this case. So apart from that, what we see in this is a os trigonum, right? An associated fluid along the flexor hallucis longus. There is subchondral irregularity here, right? And subchondral cyst or edematous changes here. So same case, we are seeing changes of posterior impingement. Let me take you through further images. So what we are seeing here is flexor hallucis longus tenosynovitis, right? And then apart from that, we can see fibrillations and thickening of the posterior talofibular ligament, and we have os trigonum. So the above mentioned findings are suggestive of complex ankle impingement in which we can see anterior and posterior components. Apart from that, we also had an osteochondral injury in this patient, and there was a ganglion cyst extending along the anterior lateral fossa. So in real life situations, it might not be only isolated findings or a single type of impingement. The patients may present a complex type of impingements, and we need to identify all the triggers for the patient's pain because the management will depend upon each type of injury, right? So this was a case of complex ankle impingement wherein we can see anterior bony projection in spur, we can see an os trigonum, and we could see the other findings. Coming to a posterior medial impingement, it is again a rare type of impingement. Patients usually present with posterior medial plane during plantar flexion inversion and it is associated with similar trauma. It is considered as a sequelae of an ankle inversion injury. Again, there is a concept of formation of the posterior medial recess and obliteration of the posterior medial recess. This happens due to an ankle inversion injury in which there might be injury to the posterior tibio-talar component of the deltoid ligament. So we have seen the anterior medial impingement in which the anterior tibio-talar portion of deltoid ligament is injured. This is, on the contrary, injury to the posterior tibio-talar component of the deltoid ligament. And the recess is, we'll talk about the recess in some time. The recess is basically formed by the posterior medial joint capsule. We have the neurovascular bundle and flexor hallucis longus tendon here. Again, damage to the posterior tibio-talar ligament may be associated with synovitis. It can encase the posterior tibial tendon, flexor hallucis tendon, and flexor digitorum longus tendon also, right? And it can present with on a radiograph. We may be able to see osteophytes along the posterior medial ankle. MRI will show edema and of edema thickening of the posterior tibial talar ligament. There might be synovitis, capsular thickening, the common sequelae that I have been talking about. There might be displacement of the tibialis posterior and flexor digitorum longus tendon. So a common differential here is pathologies of the posterior tibio-talar tendon, which has to be differentiated from posterior medial impingement. So there are certain clinical tests like TIPTO test in which they can identify and isolate whether the pathology is limited to the posterior tibial tendon, and MRI can aid in differentiating the findings also. So on an MRI, what we can see sometimes a torn or thickened posterior deltoid ligament. We can see corresponding thickening and marrow edema along the posterior tibial part. And we need to differentiate posterior medial impingement from posterior tibial tendon pathologies. So we have few clinical signs and we have MRI to help us in differentiating amongst the two. So after seeing posterior medial impingement, a common type of impingement that we are seeing more often now is an extra-articular hindfoot type of impingement. Basically, this impingement occurs in patients with severe flat foot and hindfoot valgus deformity, and they present with lateral ankle pain, primarily located along the lateral ankle near the anterior fibula and the sinus tarsi. So the pathology has been stipulated due to secondary shift of the weight-bearing forces from the talar dome to the lateral talus and fibula. It can be divided into talocalcaneal and subfibular on the degree of extension, on the degree of extent and involvement. So what happens is normally we have a normal height foot valgus and there is no, which is less than 6 degrees and there is no lateral impingement. When we have shifting of the lateral forces here, what we can see that now there is impaction happening between the talus and the calcaneum, right? And with progressive hindfoot valgus, we have abnormal contact between lateral talus and calcaneum, which can result in talocalcaneal impingement. And subsequently, if there is continuous reduction of and change in the direction of forces, what we get is a subfibular type of impingement. So, and this is the how we measure the hindfoot valgus angle, and we can see that there is subsequent increase in the hindfoot angle, and patient is having a subfibular type of impingement. So, causes of lateral hindfoot impingement can be secondary or primary. So, primary can be due to presence of an accessory anterior lateral talar facet. What happens there is because of this facet there is an accessory articulation And this can happen in patients who are young and obese. Patients are young, obese, and have a flat foot, and they can develop early extra-articular hindfoot impingement. In other secondary causes, it can be due to posterior tibial dysfunction, healed intra-articular calcaneal fractures, which has led to secondary pes planus. It may be which associated with neuropathic arthropathy and inflammatory arthritis. The pain triggers basically are secondary to osteoarthritis of the subtalar, talonavicular, and the calcaneocuboid articulations, and they have to be dealt carefully. So I found a beautiful article on lateral hindfoot impingement on DIR, and I would recommend everyone to go through this article. And we have a role of weight-bearing radiographs. I'm not going into detail about weight-bearing radiographs and multiple calculations. So, but there is an extensive role for in diagnosing and management of the pest planners when it comes to pest planners with for weight-bearing radiographs. So there is subluxation at the talocalcaneal joint. It can occur in symptomatic adults with acquired flat foot. There is lateral translocation of the calcaneus with valgus malalignment, and there is subluxation of with the anterior and middle talocalcaneal articular facet than the posterior facet. It leads to reduction of the joint space, and there is resultant subchondral cystic changes like this. So this was an 59-year-old female who presented with. So this is an example of subtalar impingement in which we can see both talocalcaneal and calcaneofibular impingement. On the sagittal images, we can see marrow edema along the opposing lateral talar processes, right? And on the coronal images, we can see edema and scarring and secondary entrapment of the calcaneofibular ligament. So this is the patient usually present with lateral ankle pain, and this is the cause. Similar case, we can see extra-articular subcortical cystic changes, corresponding bone marrow edema. We can see an increased hindfoot valgus angle. We can see soft tissue and synovitis, right? So, and this, how do we calculate this hindfoot valgus angle? It is formed by the intersection of the line which is parallel to the medial calcaneal wall and a line which is parallel to the long axis of tibia. So normally it is 6 degrees, and when it is increased, there is resultant flat foot and there is resultant impingement in chronic cases. So this was a case which was contributed by Dr. Gaurav Vasith to me, and this was a beautiful case of an accessory anterior lateral talar facet. And what we can see, there is because of this facet, there is reduction in the joint space, and there is corresponding edema and early pes planus, and patients usually present with pain along the lateral axis. A word about extra-articular impingement. Sometimes there might be dorsal talonavicular osteophytes, and there are many other causes of extra-articular impingements which I am not dealing with right now, which can cause impingement-like syndromes, restriction of the anterior range of motion, for example, in this case, and may mimic impingements. So, having a holistic approach to an anatomically based approach towards all kinds of impingements will help you in identifying the etiology, the sites of pathology, and the preferred treatment method. As musculoskeletal and interventional radiologists, it becomes important for us to identify the findings. We need to have a holistic approach and delineate other corroborative findings which can help us in ruling out other pathology. So syndromes are an important cause of chronic ankle pain, particularly in young patients and adults. We have talked about different types and presentation of impingement syndromes, and imaging plays a vital role in detection of the soft tissue and osseous abnormalities and can guide in, ultrasound guided or interventions or operative management. So thank you so much for this opportunity, Ankita. I hope I am not out of time, and I would like to thank Dr. Ankur sir, Dr. Ankita, and Dr. Gaurav for helping me with few of the cases. And before ending my talk, I also would like to welcome all of you to our national conference by MSK Society of India. So this year we are organizing a conference in Jaipur that is from 16th to 18th August, and that will be held in Jaipur. And we have lots and lots of esteemed faculties coming from all over the world and who are going to teach us about the various nuances. And we have a segregated approach. So we have people who are experts or who want to learn more about advanced musculoskeletal imaging. So we have two sections. So one is an advanced section, and one is a for refresher course in radiology for all the beginners and residents who want to start from beginning and who want to learn the musculoskeletal radiology. So please go through the website and register. And if you have queries, you can let us know, and we'll get back to you. And now, Ankita, if there are any queries pertaining to the talk, I take them.
Yeah. Um, so I can right now only see a basic query, which is what site would you recommend them to read the ankle anatomy from?
So I think they should hear your lectures on medical anatomy first, and then
That is a nice joke. Yeah, but you can go back and listen to the various talks which are available. Hmm. And there is somebody wants you to show deltoid ligament.
find deltoid